Welcome to this video entitled Lower Respiratory Tract Infections. Let's discuss a few key concepts. 1. Respiratory infections remain the major cause of morbidity from acute illness in the United States and likely represent the most common reasons why patients seek medical attention. 2. The majority of pulmonary infections follow colonization of the upper respiratory tract with potential pathogens, whereas microbes less commonly gain access to the lungs via the blood from an extrapulmonary source or by inhalation of infected aerosol particles. The competency of a patient's immune status is an important factor influencing the susceptibility to infection, etiologic cause, and disease severity. 3. An appropriate treatment regimen for the patient with uncomplicated lower respiratory tract infection usually can be established by patient history, physical examination, chest radiograph, and properly collected sputum for culture interpreted in light of current knowledge of the most common lung pathogens and their antibiotic susceptibility patterns within one's community. 4. Acute bronchitis is caused most commonly by respiratory viruses and almost always is self-limiting with therapy targeting associated symptoms, such as lethargy, malaise, or fever, ibuprofen or acetaminophen, fluids for rehydration, and in some patients cough suppressants. The routine use of antibiotics should be avoided. 5. Chronic bronchitis is a result of several contributing factors. The most prominent of these are cigarette smoking and exposure to occupational dusts, fumes, environmental pollution, and bacterial, and possibly viral, infection. The hallmark of this disease is a chronic cough with resulting sputum production and the persistent presence of microorganisms in the patient's sputum. 6. The treatment of acute exacerbations of chronic bronchitis includes attempts to mobilize and enhance sputum expectoration, chest physiotherapy, humidification of inspired air, oxygen if needed, aerosolized bronchodilators, albuterol in select patients with demonstrated benefit, and antibiotics. 7. Respiratory syncytial virus is the most common cause of acute bronchiolitis, an infection that mostly affects infants during their first year of life. In the well infant, bronchiolitis is usually a self-limiting viral illness, whereas in the child with underlying respiratory or cardiac disease or both, the child may develop severe respiratory compromise, failure, necessitating in-hospital treatment, such as rehydration, oxygen, and in select patients, bronchodilators, ribavirin aerosol, or both. 8. The most prominent pathogens causing community-acquired pneumonia in otherwise healthy adults are Streptococcus pneumoniae 70% and Mycoplasma pneumoniae 10% to 20%, whereas the most common pathogens causing hospital-acquired pneumonia, including in nursing home residents, are Staphylococcus aureus and gram-negative aerobic bacilli. Anaerobic bacteria are the most common etiologic agents in pneumonia that follows aspiration of gastric or oropharyngeal contents. 9. The treatment of community-acquired pneumonia may consist of humidified oxygen for hypoxemia, bronchodilators, albuterol when bronchospasm is present, rehydration fluids, and chest physiotherapy for marked accumulation of retained respiratory secretions. Antibiotic regimens should be selected based on presumed causative pathogens and pulmonary distribution characteristics and should be adjusted to provide optimal activity against pathogens identified by culture, sputum or blood. 10. The treatment of nosocomial pneumonia requires aggressive therapy with careful consideration of the dominance and susceptibility patterns of the pathogens present within the institution. The epidemiology of these common pathogens should be evaluated on a regular basis to identify changing resistance patterns and subsequent alternation of treatment guidelines. 1. Respiratory tract infections remain the major cause of morbidity from acute illness in the United States and most likely represent the single most common reason patients seek medical attention. This chapter focuses on bacterial and viral infections involving the lower respiratory tract, which includes the tracheobronchial tree and lung parenchyma. 2. The respiratory tract has an elaborate system of host defenses, including humoral immunity, cellular immunity, and anatomic mechanisms. When functioning properly, the host defenses of the respiratory tract are markedly effective in protecting against pathogen invasion and removing potentially infectious agents from the lungs. For the most part, infections in the lower respiratory tract occur only when these defense mechanisms are impaired, such as with dysgammaglobulinemia or compromised ciliary function caused by the chronic inflammation that accompanies cigarette smoking. In addition, local defenses may be overwhelmed when a particularly virulent microorganism or excessive inoculum invades lung parenchyma. The majority of pulmonary infections follow colonization of the upper respiratory tract with potential pathogens, which, after achieving sufficiently high concentrations, gain access to the lung via aspiration of oropharyngeal secretions. Less commonly, microbes enter the lung via the blood from an extrapulmonary source or by the inhalation of infected aerosolized particles. The specific type of pulmonary infection caused by an invading microorganism is determined by a variety of host factors, including age, anatomic features of the airway, and specific characteristics of the infecting agent. The most common infections involving the lower respiratory tract include bronchitis, bronchiolitis, and pneumonia. Lower respiratory tract infections in children and adults are most commonly a result of either viral or bacterial invasion of lung parenchyma. The diagnosis of viral infections rests primarily on the recognition of a characteristic constellation of clinical signs and symptoms. Because treatment is largely supportive, only occasionally does the diagnosis require laboratory confirmation. This is achieved through serologic tests or identification of the organism by culture or antigen detection in respiratory secretions. New laboratory techniques employing polymerase chain reaction (PCR) technology have emerged as a means to identify specific pathogens rapidly and accurately. In contrast, because bacterial pneumonia usually necessitates expedient, effective, and specific antibiotic therapy, its management depends, in large part, on isolation of the etiologic agent by culture from lung tissue or secretions. The pharynx is colonized with many organisms that potentially can cause pneumonia, therefore, culture of expectorated sputum can be misleading unless the specimen is examined to ensure that it has originated from the lower respiratory tract. The gram stain provides the easiest method to distinguish lower from upper respiratory tract secretions. Moreover, through determination of the shape and color of the bacteria, the gram stain frequently narrows the microbiologic differential diagnosis sufficiently to allow accurate initial therapy. Scanned under low-power microscopy, gram-stained expectorated upper respiratory tract secretions contain many irregularly shaped epithelial cells with little evidence of inflammation. Microorganisms of a variety of morphologies are present, as shown in Figure 106-1. In contrast, a lower tract specimen from a patient with bacterial pneumonia usually contains multiple neutrophils per high-powered field and a single or predominant bacterial species. Culture of specimens confirmed to originate from the lower tract by gram stain provides valuable diagnostic information in the majority of patients with bacterial pneumonia. 3. An appropriate treatment regimen for the patient with an uncomplicated lower respiratory tract infection usually can be established by history, physical examination, chest radiograph, and properly collected sputum cultures interpreted in light of the most common lung pathogens and their antibiotic susceptibility patterns within one's community. More sophisticated or invasive diagnostic methods, such as computed tomography, bronchoscopy, and lung biopsy, should be reserved for very ill patients who are unable to expectorate sputum or who are not responding to empirical therapy, or for pulmonary infections occurring in immunocompromised patients. Pause the video and carefully scrutinize Figure 106.1 illustrating gram stain of sputum before advancing to the next slide. Next we will discuss bronchitis. Bronchitis and bronchiolitis are inflammatory conditions of the large and small elements, respectively, of the tracheobronchial tree. The inflammatory process does not extend to the alveoli. Bronchitis frequently is classified as acute or chronic. Acute bronchitis occurs in all ages, whereas chronic bronchitis primarily affects adults. Bronchiolitis is a disease of infancy. Next we will discuss acute bronchitis. Let's begin with its epidemiology and etiology. Acute bronchitis occurs most commonly during the winter months, following a pattern similar to those of other acute respiratory tract infections. Cold, damp climates, the presence of high concentrations of irritating substances, such as air pollution or cigarette smoke, or both may precipitate attacks. Respiratory viruses are by far the most common infectious agents associated with acute bronchitis. The common cold viruses, rhinovirus and coronavirus, and lower respiratory tract pathogens, including influenza virus and adenovirus, account for the majority of cases. In children, similar pathogens are observed with the addition of the parainfluenza viruses. While the true incidence remains to be defined, Mycoplasma pneumoniae also appears to be a frequent cause of acute bronchitis. Additionally, Chlamydia pneumoniae and Bordetella pertussis, the agent responsible for whooping cough, have been associated with acute respiratory tract infections. Although a variety of bacteria, including Streptococcus pneumoniae, Streptococcus species, Staphylococcus species, and Haemophilus species, may be isolated from throat or sputum culture, it is probable that these organisms represent contamination by normal flora of the upper respiratory tract rather than true pathogens. Although a primary bacterial etiology for acute bronchitis appears rare, secondary bacterial infection may be involved. Pause the video and carefully scrutinize Table 106.1 summarizing clinical presentation of acute bronchitis before advancing to the next slide. We will now discuss the pathogenesis of acute bronchitis. Because acute bronchitis is primarily a self-limiting illness and rarely a cause of death, few data are available to describe the pathology. In general, infection of the trachea and bronchi yields hyperemic and edematous mucous membranes with an increase in bronchial secretions. Destruction of respiratory epithelium can range from mild to extensive and may affect bronchial mucociliary function. In addition, the increase in bronchial secretions, which can become thick and tenacious, further impairs mucociliary activity. The probability of permanent damage to the airways as a result of acute bronchitis remains unclear. However, epidemiologic evaluations support the belief that recurrent acute respiratory infections may be associated with increased airway hyperreactivity and possibly the pathogenesis of asthma or chronic obstructive pulmonary disease (COPD). Next we will discuss the clinical presentation of acute bronchitis. Acute bronchitis usually begins as an upper respiratory infection with nonspecific complaints, as shown in Table 106.1. Cough is the hallmark of acute bronchitis and occurs early. The onset of cough may be insidious or abrupt, and the symptoms persist despite resolution of nasal or nasopharyngeal complaints. Frequently, the cough is initially non-productive, but progresses, yielding mucopurulent sputum. In older children and adults, the sputum is raised and expectorated. In the young child, sputum is often swallowed and can result in gagging and vomiting. Substantial discomfort may result from the coughing. dyspnea, cyanosis, or signs of airway obstruction are observed rarely unless the patient has underlying pulmonary disease, such as emphysema or COPD. Fever, when present, rarely exceeds 39 degrees Celsius, that is 102.2 degrees Fahrenheit, and appears most commonly with adenovirus, influenza virus, and Mycoplasma pneumoniae infections. The diagnosis typically is made on the basis of a characteristic history and physical examination. Bacterial cultures of expectorated sputum generally are of limited use because of the inability to avoid normal nasopharyngeal flora by the sampling technique. In routine cases, viral cultures are unnecessary and frequently unavailable. Viral antigen detection tests, developed to identify respiratory viral antigens from nasal secretions rapidly, can be obtained in many hospital laboratories and in some practice settings when a specific diagnosis is necessary for clinical or epidemiologic reasons. Cultures or serologic diagnosis of Mycoplasma pneumoniae and culture or direct fluorescent antibody detection for Bordetella pertussis should be obtained in prolonged or severe cases when epidemiologic considerations would suggest their involvement. Next we will discuss the treatment of acute bronchitis. Let's begin with the desired outcome. In the absence of a complicating bacterial superinfection, acute bronchitis is almost always self-limiting. The goals of therapy, therefore, are to provide comfort to the patient and, in the unusually severe case, to treat associated dehydration and respiratory compromise. Next we will discuss a general approach to treatment of acute bronchitis. The treatment of acute bronchitis is symptomatic and supportive in nature. Reassurance and antipyretics frequently are all that are needed. Bed rest for comfort may be instituted as desired. Patients should be encouraged to drink fluids to prevent dehydration and possibly to decrease the viscosity of respiratory secretions. Mist therapy, the use of a vaporizer, or both may further promote the thinning and loosening of respiratory secretions. We will now discuss the pharmacologic therapy of acute bronchitis. Mild analgesic antipyretic therapy is often helpful in relieving the associated lethargy, malaise, and fever. Aspirin or acetaminophen, dosed at 650 mg in adults or 10 to 15 mg per kilogram per dose in children, maximum daily pediatric dose 60 mg per kilogram, maximum daily adult dose 4 grams, or ibuprofen 200 to 800 mg in adults or 10 mg per kilogram per dose in children, maximum daily pediatric dose 40 mg per kilogram. Maximum daily adult dose 3.2 grams should be administered every 4 to 6 hours. In children, aspirin should be avoided and acetaminophen used as the preferred agent because of the possible association between aspirin use and the development of Reyes syndrome. The use of ibuprofen as an antipyretic has increased. The drug's antipyretic efficacy appears identical to that of aspirin or acetaminophen, although its duration of antipyretic effect may be slightly longer, e.g., 3 to 4 hours for aspirin and acetaminophen versus 5 to 6 hours for ibuprofen. Caution should be exercised in the administration of ibuprofen in those younger than 3 months of age and elderly patients and individuals with poor renal function. Aspirin and ibuprofen inhibit prostaglandin synthesis and may adversely influence renal function in these predisposed patient populations. Patients suffering from acute bronchitis frequently medicate themselves with over-the-counter OTC cough and cold remedies containing various combinations of antihistamines, sympathomimetics, and antitussives despite the lack of definitive evidence supporting their effectiveness. In fact, the tendency of these agents to dehydrate bronchial secretions potentially could aggravate and prolong the recovery process. Persistent, mild cough, which may be bothersome, can be treated with dextromethorphan. More severe coughs may require intermittent codeine or other similar agents. In severe cases, cough may be persistent enough to disrupt sleep, and the use of a mild sedative hypnotic, concomitantly with a cough suppressant, may be desirable. However, antitussives should be used cautiously when the cough is productive. The primary or supplemental use of expectorants is questionable because the clinical effectiveness has not been well established. Routine use of antibiotics in the treatment of acute bronchitis should be discouraged. However, in patients who exhibit persistent fever or respiratory symptoms for more than 4 to 6 days, the possibility of a concurrent bacterial infection should be suspected. When possible, antibiotic therapy should be directed toward anticipated respiratory pathogens, Streptococcus pneumoniae, Haemophilus influenza. Mycoplasma pneumoniae, if suspected by history or positive cold agglutinins titers greater than 1 to 32, or if confirmed by culture or serology, may be treated with erythromycin or its analogues, clarithromycin, azithromycin. Alternatively and empirically, a fluoroquinolone with activity against these pathogens, e.g., gatafloxacin or levofloxacin, may be used. During known epidemics involving the influenza virus, amantadine or rimantadine may be effective in minimizing associated symptoms if administered early in the course of the disease. The recently marketed neuraminidase inhibitors, zanamivir and oseltamivir, are active against both influenza A and B viral infections and may reduce the severity and duration of the influenza episode if administered promptly during the onset of the viral infection. Next we will discuss chronic bronchitis. Let's begin with its epidemiology and etiology. Chronic bronchitis is a nonspecific disease that primarily affects adults. Between 10% and 25% of the adult population 40 years of age or older suffer from chronic bronchitis, resulting in substantial healthcare dollar expenditures and lost wages. This disease is so common that acute bronchitis and acute exacerbations of chronic bronchitis result in approximately 14 million physician visits per year in the United States. Similar to acute bronchitis, cold, damp climates and the presence of elevated airborne concentrations of irritating substances may favor this disease. Chronic bronchitis occurs more commonly in men than in women. Chronic bronchitis is a result of several contributing factors. The most prominent of these include cigarette smoking, exposure to occupational dusts, fumes, and environmental pollution, and bacterial, and possibly viral, infection. The influence that each of these factors and others, either alone or in combination, contributes to chronic bronchitis is unknown. Cigarette smoke is a well-known airway irritant and is believed to be the predominant factor in the etiology of chronic bronchitis. Studies of lungs from smoking and non-smoking individuals clearly have demonstrated a substantial increase in the number of alveolar macrophages, as well as the presence of bronchial inflammation, in individuals who smoke cigarettes. Although the majority of patients who suffer from chronic bronchitis have a positive smoking history, no history of smoking can be identified in as many as 10% of patients. These findings suggest that additional airway irritants, either alone or more probably in combination, are responsible for the pathogenesis of chronic bronchitis. The only known genetic abnormality leading to COPD is alpha-1 antitrypsin deficiency, which occurs in less than 1% of COPD patients in the United States. In addition, the influence of recurrent respiratory tract infections during childhood or young adult life on the later development of chronic bronchitis remains obscure. Recurrent respiratory infections at a young age may predispose individuals to the development of chronic bronchitis. However, it is unclear whether these recurrent respiratory tract infections are a result of unrecognized anatomic abnormalities of the airways or impaired pulmonary defense mechanisms. We will now discuss the pathogenesis of chronic bronchitis. The chronic inhalation of an irritating noxious substance compromises the normal secretory and mucociliary function of bronchial mucosa. In chronic bronchitis, the bronchial wall is thickened, and the number of mucus-secreting goblet cells in the surface epithelium of both larger and smaller bronchi is increased markedly. In contrast, goblet cells generally are absent from the smaller bronchi of normal individuals. In addition to the increased number of goblet cells, hypertrophy of the mucus glands and dilation of the mucus gland ducts are also observed. As a result of these changes, chronic bronchitics have substantially more mucus in the peripheral airways, further impairing normal lung defenses. This increased quantity of tenacious secretions within the bronchial tree frequently causes mucus plugging of the smaller airways. Accompanying these changes are squamous cell metaplasia of the surface epithelium, edema and increased vascularity of the basement membrane of larger airways, and variable chronic inflammatory cell infiltration. Continued progression of this pathology can result in residual scarring of small bronchi, augmenting airway obstruction and weakening of bronchial walls. We will now discuss the clinical presentation of chronic bronchitis. The hallmark of chronic bronchitis is a cough that may range from a mild, smoker's cough, to severe, incessant coughing productive of purulent sputum. Coughing may be precipitated by multiple stimuli, including simple, normal conversation. Expectoration of the largest quantity of sputum usually occurs on arising in the morning, although many patients expectorate sputum throughout the day. The expectorated sputum usually is tenacious and can vary in color from white to yellow-green. As a result, many patients complain of a frequent bad taste in their mouth and of halitosis. The diagnosis of chronic bronchitis is based primarily on clinical assessment and history. Any patient who reports the coughing up of sputum on most days for at least 3 consecutive months each year for 2 consecutive years presumptively has chronic bronchitis. The diagnosis of chronic bronchitis is made only when the possibilities of bronchiectasis, cardiac failure, cystic fibrosis, and lung carcinoma have been effectively excluded. In an attempt to be more specific in the diagnosis, some investigators have added lost wages for 3 or more weeks to the criteria. In addition, many clinicians attempt to subdivide their patients into one of 3 subgroups. 1. Those with simple chronic bronchitis. 2. Those with chronic or recurrent mucopurulent bronchitis based on the presence of mucopurulent sputum confirmed by microscopic analysis. And 3. Those with chronic obstructive bronchitis based on the clinical history and presence of airway obstruction documented by pulmonary function testing. More recently, an ad hoc international committee comprised of pulmonary and infectious disease physicians developed a classification system that can serve as a practical guide for initial patient assessment and management, as shown in Table 106-2, for patients with chronic bronchitis. Typical clinical presentation of chronic bronchitis is found in Table 106-3. In more progressed stages of chronic bronchitis, physical findings associated with cor pulmonale, including cardiac enlargement, hepatomegaly, and edema of the lower extremities, are observed. In general, chronic bronchitics tend to maintain at least normal body weight and are commonly obese. Radiographic studies are of limited value either in the diagnosis or as a means of sequentially following a patient. The microscopic and laboratory assessment of sputum is considered an important component in the overall evaluation of patients with chronic bronchitis. A fresh sputum specimen obtained as an early morning sample is preferred. Comparison of the cellular constituents of chronic bronchitic sputum with those of normal sputum can provide insight into the degree of activity of the disease processes. An increased number of polymorphonuclear granulocytes often suggests continual bronchial irritation, whereas an increased number of eosinophils suggests an allergic component that should be further investigated. Gram staining of the sputum often reveals a mixture of both gram-positive and gram-negative bacteria, reflecting normal oropharyngeal flora and tracheal colonization by S. pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Table 106-4 outlines the most common bacterial isolates identified from sputum culture in patients experiencing an acute exacerbation of chronic bronchitis. Pause the video and carefully scrutinize Table 106-2 summarizing the classification system for patients with chronic bronchitis and initial treatment options before advancing to the next slide. Pause the video and carefully scrutinize Table 106-3 summarizing clinical presentation of chronic bronchitis before advancing to the next slide. Pause the video and carefully scrutinize Table 106-4 summarizing the common bacterial pathogens isolated from the sputum of patients with an acute exacerbation of chronic bronchitis before advancing to the next slide. We will now discuss the treatment of chronic bronchitis. Let's begin with the desired outcome. The goals of therapy for chronic bronchitis are twofold: to reduce the severity of the chronic symptoms and to ameliorate acute exacerbations and achieve prolonged infection-free intervals. Next, we will discuss a general approach to treatment. The approach to the treatment of chronic bronchitis is multifactorial. First and foremost, attempts must be made to reduce the patient's exposure to known bronchial irritants, e.g., smoking. A complete occupational and environmental history for the determination of exposure to noxious, irritating gases, as well as preference towards cigarette smoking, must be assessed. Often easier discussed than accomplished, honest, yet reasonable attempts should be made with the patient to reduce or eliminate completely the number of cigarettes smoked daily and to reduce exposure to second-hand smoke. In an organized, coordinated smoking cessation program, which includes counseling and hypnotherapy, the adjunctive use of nicotine substitutes, such as a nicotine gum or patch, may promote the reduction or complete withdrawal from cigarette smoking. Often just as difficult is the modification of exposure to irritating substances within the home and workplace. Additionally, measures to provide pulmonary toilet can be instituted. During acute pulmonary exacerbations of the disease, a patient's ability to mobilize and expectorate sputum may be reduced dramatically. In these instances, attempts at postural drainage techniques, with instruction, active participation, or both from a respiratory therapist, may assist in promoting clearance of pulmonary secretions. In addition, humidification of inspired air may promote the hydration, liquefaction, of tenacious secretions, allowing for more productive removal. The use of mucolytic aerosols, such as N-acetylcysteine and DNase, is of questionable therapeutic value, particularly considering their propensity to induce bronchospasm, N-acetylcysteine, and their excessive cost. Oral or aerosolized bronchodilators may benefit some patients during acute pulmonary exacerbations. Finally, in the face of an acute exacerbation, a trial of antibiotics directed against the most likely underlying pathogens may be initiated. We will now discuss the pharmacologic therapy of chronic bronchitis. For patients who consistently demonstrate clinical limitation in airflow, a therapeutic challenge of bronchodilators, such as albuterol aerosol, should be considered. Pulmonary function tests can be performed before and after beta-2 agonist aerosol administration to determine more objectively a patient's propensity to benefit from supplemental aerosol therapy. However, this laboratory assessment, often performed at times of better health, may not accurately predict a patient's potential benefit from beta-2 aerosols during an acute exacerbation of chronic bronchitis. Although chronic theophylline administration has been used extensively in the past, this therapy is being employed with decreasing frequency in favor of aerosolized beta-2 receptor agonists. Albuterol is used most commonly, 1 to 2 puffs of the metered dose inhaler 3 to 4 times daily. The role of aerosolized surfactant also has been assessed in patients with stable chronic bronchitis and has demonstrated encouraging results with respect to improvement in pulmonary function and sputum transport by cilia, i.e., clearance. The role of surfactant as a carrier vehicle for other aerosol medications also appears promising and most likely will continue to be evaluated. The use of antimicrobials for chronic bronchitis is controversial. Numerous comparative evaluations, including placebo-controlled studies of antibiotic administration with acute and chronic treatment of chronic bronchitis, have suggested definite clinical benefit, whereas other similar studies have not. The antibiotics selected most frequently possess variable in vitro activity against the common sputum isolates Haemophilus influenza, Streptococcus pneumoniae, Moraxella catarrhalis, and Mycoplasma pneumoniae. In general, these conflicting results appear independent of which antibiotic was used or regimen compared. The wide disparity that exists in the results from these studies, combined with the difficulties in recognition and lack of standardized diagnostic criteria for acute exacerbation of chronic bronchitis, serves as the basis for the enormous controversy surrounding the use of antibiotics in this condition. Further complicating antibiotic selection is the increasing resistance of the common bacterial pathogens to first-line agents. As many as 30% to 40% of Haemophilus influenza and 95% of Moraxella catarrhalis produce beta-lactamase. Moreover, up to 30% of Streptococcus pneumoniae isolates demonstrate resistance to penicillin, minimum inhibitory concentration (MIC) equal to 0.1 to 2 mg per liter, with approximately 14% of isolates being highly resistant, that is an MIC greater than 2 mg per liter. In addition, concern for Streptococcus pneumoniae resistance is increasing because the incidence of macrolide resistance is approximately 20%. Despite these changes in bacterial susceptibility, it is recommended to initiate therapy with first-line agents in less severely affected patients. The scheme outlined in Table 106-2 can be used as an initial guide in the selection of antibiotics based on disease severity, classes 1 through 4. These guidelines are quite consistent with those recently published by the Canadian Thoracic and Infectious Disease Societies. Regardless of which antibiotic is selected, careful attention to predetermined outcome measures should be monitored closely in each patient to determine the success or failure of the therapeutic intervention. Oral antibiotics with broader antibacterial spectra, e.g., cefixime, amoxicillin clavulanate, fluoroquinolones, or azalides that possess more potent in vitro activity against sputum isolates generally are not needed as initial therapy because clinical response often appears independent of the pathogen's in vitro susceptibility for many patients. An important clinical outcome, variable directing drug selection and criteria for beginning antibiotics in individual patients is the infection-free period when chronic bronchitis are off antibiotics. The actual length of the infection-free time period, as well as the change in the number of physician office visits and hospital admissions with a particular antibiotic regimen, are extremely important to identify, whenever possible, for each patient. The antibiotic regimen that results in the longest infection-free period defines the regimen of choice for specific patients for future acute exacerbations of the disease. Antibiotics should be selected that are effective against responsible pathogens, that demonstrate the least risk of drug interactions, and that can be administered in a manner that promotes compliance. Antibiotics commonly used in the treatment of these patients and their respective adult starting doses are outlined in Table 106.5. Doses of antibiotics should be adjusted as needed to the desired clinical effect and the lowest incidence of acceptable side effects. A frequently used clinical strategy to enhance the duration of symptom-free periods incorporates higher-dose antibiotic regimens using the upper limit of the recommended daily antibiotic dose for a period of 10 to 14 days. Traditionally, ampicillin has been considered the drug of choice for the treatment of acute exacerbations of chronic bronchitis. Unfortunately, the need for multiple repeat daily doses, 4 times daily, increased incidence of gastrointestinal side effects, and the increasing incidence of penicillin-resistant beta-lactamase producing strains of bacteria, see tables 106.2 and 106.4, have limited the usefulness of this safe and very cost-effective antibiotic. As stated earlier, the proposed classification system outlined in Table 106.2 offers first- and second-line treatment options for acute exacerbations of chronic bronchitis that are directed by the baseline clinical status of the patient. These treatment recommendations can be used to initiate therapy in patients with Class 1 through 4 disease. The value of the erythromycins when mycoplasma is involved is unquestionable, whereas the value, if any, of the newer erythromycin analogues azithromycin or clarithromycin as first-line agents in the treatment of these patients is unknown. Azithromycin should be considered as the macrolide or azalide of choice when considering the drug's in vitro antibacterial spectrum of activity, tissue distribution characteristics, and lack of metabolic-based drug-drug interactions. In contrast, the fluoroquinolones have emerged as effective alternative agents, particularly when gram-negative pathogens are involved or in more clinically or severely ill patients, see Table 106.2. The increasing resistance of selected pathogens to ciprofloxacin may necessitate the use of newer analogues with greater in vitro antibacterial activity, including penicillin-tolerant or resistant Streptococcus pneumoniae, e.g., gatafloxacin. The increased cost of fluoroquinolones may be outweighed by the possible superiority of fluoroquinolones in their apparent initial success rate and more prolonged infection-free time period. In the patient whose history suggests recurrent exacerbations of disease that might be attributable to specific events, i.e., it is seasonal or related to the winter months, a trial of prophylactic antibiotics might be beneficial. If no clinical improvement is noted over an appropriate time period 2 to 3 months per year for 2 to 3 years, further attempts at prophylactic therapy could be discontinued. Similarly, patient-specific antibiotic trials could be performed in individuals experiencing acute exacerbations, focusing on defining the infection-free period. Although less than desirable, this method of clinical assessment may distinguish patients who will benefit from prophylactic antibiotic therapy from those who will not. Pause the video and carefully scrutinize Table 106.5 summarizing oral antibiotics commonly used for the treatment of acute respiratory exacerbations in chronic bronchitis before advancing to the next slide. We will now discuss bronchiolitis. Let's begin with its epidemiology and etiology. Bronchiolitis is an acute viral infection of the lower respiratory tract, most commonly affecting infants during the first year of life, with peak attack rates occurring in infants between the ages of 2 and 10 months. Infectious bronchiolitis is unusual in children older than 2 years of age. The occurrence of bronchiolitis peaks during the winter months and persists through early spring. Bronchiolitis remains a major reason why infants younger than 6 months of age require hospitalization. The hospitalization rate for infants younger than 6 months of age for bronchiolitis approximates 6 per 1,000 children per year. The incidence of bronchiolitis appears to be more common in males than in females. Respiratory syncytial virus (RSV) is the most common cause of bronchiolitis, accounting for 45% to 60% of all cases. During epidemic periods, the incidence of RSV-induced bronchiolitis can exceed 80% of cases. Parainfluenza viruses type 3 10% to 15%, type 1 that is 5% to 10%, and type 2 that is 1% to 5% are the second most common pathogens, constituting as a group nearly 25% of cases. Bacteria serve as secondary pathogens in a minority of cases. Pause the video and carefully scrutinize Table 106.6 summarizing clinical presentation of bronchiolitis before advancing to the next slide. We will now discuss the clinical presentation of bronchiolitis. A prodrome suggesting an upper respiratory tract infection, usually lasting from 2 to 7 days, precedes the onset of clinical symptoms. Table 106.6. As a result of limited oral intake because of coughing combined with fever, vomiting, and diarrhea, infants frequently are dehydrated. The increased work of breathing and tachypnea most likely further increases fluid loss. In most cases, this clinical picture persists between 3 and 7 days. Although the hospital course of bronchiolitic children is often variable, substantial clinical improvement usually is observed within the first 2 days, with gradual improvement and resolution over the next 7 to 21 days. The diagnosis of bronchiolitis is based primarily on history and clinical findings. It is important for the clinician to attempt to differentiate between bronchiolitis and a host of other clinical entities affecting infants, which may produce a similar picture of dyspnea and wheezing. Asthma, congestive heart failure, anatomic airway abnormalities, cystic fibrosis, foreign bodies, and gastroesophageal reflux are the primary disease entities that may present with wheezing on physical examination in children. The isolation of a viral pathogen in the respiratory secretions of a wheezing child establishes a presumptive diagnosis of infectious bronchiolitis. The ability to identify specific viral pathogens is, however, often hindered by the limited availability of special virology laboratories. The proliferation of commercial enzyme-linked immunosorbent assays, abbreviated as ELISA, and fluorescent antibody staining techniques of nasopharyngeal secretions has increased the ability to identify viral antigens within several hours. Identification of RSV by PCR should be available routinely from most clinical laboratories, but its relevance to the clinical management of bronchiolitis remains obscure. Multiple clinical laboratory determinations have been used to assist in the management of cases of bronchiolitis. Röntgenographic evaluation of the chest in children with bronchiolitis yields variable findings, but may help to distinguish this illness from other entities characterized by wheezing. In children requiring hospitalization, abnormalities in blood gas tensions are frequent and appear to relate to disease severity. Hypoxemia is common and increases the respiratory drive, whereas hypocarbia is seen only in the most severe cases. Despite the presence of moderate degrees of hypoxemia, clinical cyanosis is unusual. We will now look at the treatment of bronchiolitis. Let's begin with the desired outcome. In the well infant, bronchiolitis is usually a self-limiting illness, and reassurance and antipyretics are usually all that are necessary while waiting for resolution of the underlying viral infection. In-hospital support is necessary for the child suffering from respiratory failure or dehydration. Underlying cardiac and pulmonary diseases potentiate these conditions. We will now discuss a general approach to treatment of bronchiolitis. Almost all otherwise healthy babies with bronchiolitis can be followed as outpatients. Such infants are treated for fever, provided generous amounts of oral fluids, and observed closely for evidence of respiratory deterioration. In severely affected children, the mainstays of therapy for bronchiolitis are oxygen therapy and intravenous fluids. In a subset of patients, aerosolized bronchodilators may have a role. In selected infants, particularly those with underlying pulmonary or cardiac disease or both, with severe acute infection, therapy with the antiviral agent ribavirin may be considered. Next we will discuss the pharmacologic therapy of bronchiolitis. Aerosolized beta-2 adrenergic therapy appears to offer little benefit for the majority of patients and may even be detrimental. However, this therapy may offer some benefit to the child with a predisposition toward bronchospasm. In hospitalized patients, bronchodilator therapy may be offered initially, but should not be pursued in the absence of a clear-cut clinical benefit. Similarly, controlled trials of corticosteroids have failed to reveal any therapeutic benefit or harmful effect when administered to bronchiolytic infants. As a result, the routine use of systemically administered corticosteroids is discouraged. Although it has been common practice to place children with bronchiolitis in mist tents, there are no data to document the effectiveness of this practice. We will now discuss a clinical controversy. Because bacteria do not represent primary pathogens in the etiology of bronchiolitis, antibiotics should not be administered routinely. Despite this, many clinicians frequently administer antibiotics initially while awaiting culture results because the clinical and radiographic findings in bronchiolitis are often suggestive of a possible bacterial pneumonia. Ribavirin may offer benefit to a subset of infants with bronchiolitis. Although ribavirin, a synthetic nucleoside, possesses in vitro antiviral properties against a variety of RNA and DNA viruses, including influenza A, influenza B, parainfluenza, and adenovirus, it is approved only in aerosolized form against RSV. Use of the drug requires special equipment, that is a small particle aerosol generator, and specially trained personnel for administration via oxygen hood or mist tent. Special care must be taken to avoid drug particle deposition and the resulting clogging of respiratory tubing and valves in mechanical ventilators. Among hospital admissions for RSV infection, ribavirin therapy failed to decrease length of hospital stay, number of days in the intensive care unit, or number of days receiving mechanical ventilation. Consequently, the American Academy of Pediatrics has modified its recommendation for the use of ribavirin from "should be used" to "may be considered." In light of this and because of the requirement for special aerosolization equipment and the cost of the drug itself, most experts recommend reserving use of ribavirin for severely ill patients, especially those with chronic lung disease, particularly bronchopulmonary dysplasia, congenital heart disease, prematurity, and immunodeficiency, especially severe combined immunodeficiency and human immunodeficiency virus (HIV) infection. Ribavirin also may be considered in otherwise healthy patients with severe distress because of RSV infection. In infants with underlying pulmonary or cardiovascular disease, prophylaxis against RSV may be warranted. When administered monthly during the RSV season, both respiratory syncytial virus immune globulin, abbreviated as RSV-IG, and palivizumab, a monoclonal antibody for RSV, may decrease the number of RSV episodes and the need for hospitalization. Among the two, palivizumab appears to be preferred, given its ease of administration, lack of administration-related adverse effects, and non-interference with select immunizations. Next we will discuss pneumonia. Let's begin with its epidemiology. Pneumonia is the most common infectious cause of death in the United States, where approximately 4 million cases are diagnosed annually at a cost of $23 billion redundant to the health care system. Pneumonia occurs throughout the year, with the relative prevalence of disease resulting from different etiologic agents varying with the seasons. It occurs in persons of all ages, although the clinical manifestations are most severe in the very young, the elderly, and the chronically ill. Next we will discuss the pathogenesis of pneumonia. Microorganisms gain access to the lower respiratory tract by three routes. They may be inhaled as aerosolized particles, or they may enter the lung via the bloodstream from an extrapulmonary site of infection. However, aspiration of oropharyngeal contents, a common occurrence in both healthy and ill persons during sleep, is the major mechanism by which pulmonary pathogens gain access to the normally sterile lower airways and alveoli. When pulmonary defense mechanisms are functioning optimally, aspirated microorganisms are cleared from the region before infection can become established. However, aspiration of potential pathogens from the oropharynx can result in pneumonia if lung defenses are impaired. Factors that promote aspiration, such as altered sensorium and neuromuscular disease, may result in an increase in the size of the inoculum delivered to the lower respiratory tract, thereby overwhelming local defense mechanisms. Lung infections with viruses suppress the antibacterial activity of the lung by impairing alveolar macrophage function and mucociliary clearance, thus setting the stage for secondary bacterial pneumonia. Mucociliary transport is also depressed by ethanol and narcotics and by obstruction of a bronchus by mucus, tumor, or extrinsic compression. All these factors can severely impair the pulmonary clearance of aspirated bacteria. The most prominent pathogens causing community-acquired pneumonia in otherwise healthy adults are Streptococcus pneumoniae, also known as pneumococcus, and Mycoplasma pneumoniae. Pneumococcus is the most common cause of bacterial pneumonia in all age groups and accounts for up to 70% of all acute bacterial pneumonias in the United States. Mycoplasma pneumoniae is believed to account for 10% to 20% of cases. Legionella, Chlamydia pneumoniae, and a variety of viruses also cause pneumonia among otherwise healthy persons. Community-acquired pneumonias caused by Staphylococcus aureus and gram-negative rods are observed primarily in the elderly, especially those residing in nursing homes, and in association with alcoholism and other debilitating conditions. The term atypical may be applied to pneumonia to indicate that the pneumonia may be caused by an atypical pathogen. Although this is older terminology that is slowly fading, a reference to atypical pneumonia or atypical pathogens refers to pneumonia, i.e., bilateral lobar pneumonia with a negative gram stain caused by Mycoplasma pneumoniae, Chlamydia pneumoniae, or Legionella. Gram-negative aerobic bacilli and Staphylococcus aureus are the leading causative agents in hospital-acquired pneumonia. Anaerobic bacteria are the most common etiologic agents in pneumonia that follows the gross aspiration of gastric or oropharyngeal contents. Pneumonia in infants and children is caused by a wider range of microorganisms, and unlike in adults, non-bacterial pathogens predominate. Most pneumonias in the pediatric age group are caused by viruses, especially RSV, parainfluenza, and adenovirus. Mycoplasma pneumoniae is an important pathogen in older children. Beyond the neonatal period, pneumococcus is the major bacterial pathogen in childhood pneumonia, followed by Grouper Streptococcus and Staphylococcus aureus. Haemophilus influenza type B, once a major childhood pathogen, has become an infrequent cause of pneumonia since the introduction of active vaccination against this organism in the late 1980s. Pause the video and carefully scrutinize Table 106-7 summarizing clinical presentation of pneumonia before advancing to the next slide. We will now discuss the clinical presentation of bacterial pneumonia. Bacterial pneumonia is caused most commonly by gram-positive streptococci and staphylococci and gram-negative organisms that normally inhabit the gastrointestinal tract, also called the enterics, and soil and water, also called the known enterics. In addition, Legionella pneumophila, itself a weakly staining gram-negative non-enteric organism, accounts for a small percentage of community and hospital-acquired bacterial pneumonia. Finally, Mycobacterium tuberculosis, an acid-fast staining bacillus, has re-emerged as an important cause of pneumonia in urban centers throughout the United States. Although a wide array of gram-positive and gram-negative organisms can cause pneumonia, they usually present a similar clinical appearance, as shown in Table 106-7. Pneumococcus, staphylococcus, the enteric gram-negative rods, and occasionally other organisms may produce local irritation or destruction of blood vessels leading to rust-colored sputum or hemoptysis. Pleural effusions, both sterile and empyematous, may be associated with many of these entities, evidenced by distant breath sounds and a wide area of dulled percussion. The chest radiograph and sputum examination and culture are the most useful diagnostic tests in gram-positive and gram-negative bacterial pneumonia. Typically, the chest radiograph reveals a dense lobar or segmental infiltrate. Patchy consolidation may be seen occasionally, however, with virtually all these pathogens. Occasionally, pneumonia resulting from hematogenous spread of the organisms results in a diffuse, alveolar pattern on chest radiograph. Gram stain of the expectorated sputum demonstrates many polymorphonuclear cells per high-powered field in the presence of a predominant organism, see Fig. 106-1, which is reflected in heavy growth of a single species on culture. Other laboratory tests are less sensitive or specific. Blood cultures may be helpful in identifying the offending organism, but are positive in only a minority of patients. The complete blood count usually reflects a leukocytosis with a predominance of polymorphonuclear cells. In some instances, particularly with pneumococcus, the elevation of the white blood cell (WBC) count may be pronounced. Normal or mildly elevated WBC counts, however, do not exclude bacterial pneumonic disease. The patient also may be hypoxic, as reflected by low oxygen saturation on arterial blood gas or pulse oximetry. Although the clinical appearance of the gram-positive and gram-negative pneumonias is similar, there are epidemiologic and clinical clues that render one more likely than the other. Next we will discuss gram-positive bacteria. Pneumococcus is the most common community-acquired bacterial pneumonia, accounting for 25% to 70% of cases. It is particularly prevalent and severe in patients with splenic dysfunction, diabetes mellitus, chronic cardiopulmonary or renal disease, or HIV infection. Staphylococcus aureus pneumonia occurs in both the community and hospital settings. Community-acquired disease with Staphylococcus aureus is identified most frequently in young infants, patients with early cystic fibrosis, and those recovering from an antecedent respiratory viral infection. Staphylococcus aureus is a prominent cause of nosocomial pneumonia and may result from hematogenous spread from a distant source. In both settings, it is characteristically severe and accompanied by the formation of pneumatoceles, that is, the air-containing cavities within the lung. Group B Streptococcus, although rare in adults, is the most common cause of bacterial pneumonia among neonates, where it typically causes a clinical and radiographic picture nearly indistinguishable from hyaline membrane disease. Group A Streptococcus is an uncommon cause of community-acquired pneumonia and frequently occurs after a viral respiratory tract infection. Only occasionally is it associated with streptococcal pharyngitis. The organism is pyogenic and the presentation can be severe. Next we will discuss enteric gram-negative bacteria. Community-acquired enteric gram-negative pneumonia is identified most frequently among patients with chronic illness, especially alcoholism and diabetes mellitus. The enteric gram-negative bacteria are also leading causes of nosocomial pneumonia because the upper respiratory tract becomes rapidly colonized with gram-negative organisms after hospitalization, particularly among critically ill patients and those receiving antibiotics. Outbreaks of nosocomial disease may be caused occasionally by contaminated respiratory therapy equipment. Klebsiella pneumoniae is the most frequently encountered pathogen among the gram-negative enteric bacteria, although the relative prominence of these organisms varies from hospital to hospital. The gram-negative bacilli are associated with high mortality, sometimes exceeding 50%. Their potential to produce significant morbidity and mortality also has been enhanced by the emergence of highly antibiotic-resistant organisms in some hospital settings. Next we will discuss non-enteric gram-negative bacteria. The most prominent non-enteric gram-negative rods associated with pneumonia include Pseudomonas, Haemophilus, and Moraxella. Like the enteric gram-negative organisms, Pseudomonas aeruginosa is a frequent cause of hospital-acquired pneumonia and is particularly prominent among neutropenic and burn patients. In addition, cystic fibrosis patients suffer from chronic, multilobar infections with Pseudomonas aeruginosa, as well as other Pseudomonas species. These infections are punctuated with acute exacerbations. Haemophilus influenza type B historically has been a prominent pathogen in childhood pneumonia. Since the introduction of the conjugated Haemophilus vaccines in the late 1980s, however, there has been a dramatic drop in the incidence of all-invasive disease owing to this organism in the pediatric age group. Two different clinical presentations of Haemophilus influenza pneumonia are still seen in adults, however. The most common by far is the bronchopneumonia form, which develops most frequently in patients with underlying chronic lung disease and is believed to represent, in most patients, an exacerbation of chronic bronchitis. In the second form of Haemophilus influenza pneumonia, segmental or lobar involvement predominates. The course of this illness is more acute, with sudden onset of cough, fever, and pleuritic chest pain. Finally, Moraxella catarrhalis, an important cause of otitis media and sinusitis, has been found to be an increasingly important cause of lower respiratory tract infections in immunocompetent and hospitalized patients. Next we will discuss Legionella pneumophila. Of the several Legionella spp. Known to cause pneumonia in humans, Legionella pneumophila is by far the most important and accounts for 2% to 15% of all community-acquired pneumonias in North America and Europe. Legionella is a water and soil organism and most probably is transmitted by the inhalation of aerosols containing the organism or by microaspiration of contaminated water. Outbreaks of illness caused by Legionella pneumophila have been linked to excavation sites and to contaminated water from air conditioners and showers. Person-to-person transmission has not been demonstrated. In addition to epidemics, Legionella pneumophila causes sporadic illness that peaks in summer and fall. Individuals who are male, middle-aged or older, immunocompromised, chronic bronchitis, or cigarette smokers are at increased risk. Infection with Legionella pneumophila is characterized by multisystem involvement, including rapidly progressive pneumonia. It has a gradual onset with prominent constitutional symptoms, such as malaise, lethargy, weakness, and anorexia, occurring early in the course of the illness. A dry, non-productive cough is present initially that becomes productive of mucoid or purulent sputum over several days. Fevers exceeding 40 degrees Celsius, that is 104 degrees Fahrenheit, develop in more than half of patients and typically are unremitting and associated with a relative bradycardia. Pleuritic chest pain and progressive dyspnea may be seen. Extrapulmonary symptoms remain evident throughout the course of the illness, particularly diarrhea, nausea, and vomiting. Myalgias and arthralgias also occur. Substantial changes in a patient's mental status, often out of proportion to the degree of fever, are seen in approximately 1/4 of patients. Obtundation, hallucinations, grand mal seizures, and focal neurologic findings are also associated with this illness. Chest röntgenograms initially reveal patchy alveolar infiltrates that may be bilateral. Progression to lobar or multilobar consolidation is frequent, as are small pleural effusions. Laboratory findings include leukocytosis with a predominance of mature and immature granulocytes in 50% to 75% of patients. Urinalysis may reveal proteinuria, hematuria, and casts. Liver function tests may be abnormal. Hyponatremia and hypophosphatemia also have been reported frequently. Because Legionella pneumophila stains poorly with commonly used stains, routine microscopic examination of sputum is of little diagnostic value. While it exhibits slow growth and has highly selective growth requirements, Legionella pneumophila has been isolated successfully from tissue using a specialized medium. Direct fluorescent antibody examination of respiratory tract secretions, lung tissue, or pleural fluid is the most rapid means of establishing the diagnosis. The sensitivity of this method approaches 70% for sputum and 90% for lung tissue, and diagnostic specificity is high for both. Commercially available urine antigen tests have been developed for Legionella pneumophila. These tests are 70% sensitive and remain positive for weeks, even after effective antibiotics have been started. Because these diagnostic tests are unavailable in many clinical laboratories, the diagnosis of Legionnaire's disease often is presumptive and based on a suggestive clinical presentation. Next we will discuss anaerobic pneumonia. Anaerobic pneumonitis is most likely to occur in individuals predisposed to aspiration by impaired consciousness and may be more prevalent in those with periodontal disease or dysphagia. In addition, bronchogenic carcinoma is an associated underlying condition. A variety of gram-positive and gram-negative anaerobic bacteria indigenous to the upper airway may cause pneumonitis when large quantities of oropharyngeal secretions are aspirated into the lower airways. The organisms most frequently implicated are Peptostreptococcus species, Fusobacteria, Bacteroides melanogenicus, Bacteroides fragilis, and Peptococcus species. Polymicrobial infections with anaerobes and aerobes, such as Staphylococcus aureus, Streptococcus pneumoniae, and gram-negative bacilli, are common. The course of illness typically is indolent, with cough, low-grade fever, and weight loss, although an acute presentation may occur. Rigors are notably absent and bacteremia is rare. Putrid sputum, when present, is highly suggestive of the diagnosis. Chest radiographs reveal infiltrates typically located in dependent lung segments, and lung abscesses develop in 20% of patients 1 to 2 weeks into the course of the illness. Next we will discuss tuberculosis. The acid-fast Bacillus mycobacterium tuberculosis causes tuberculosis. After years of steady decline, the number of cases of pneumonia caused by Mycobacterium tuberculosis in the United States began to increase in the middle to late 1980s. The new epidemic was a consequence of an increased incidence in prison inmates, intravenous drug abusers, immigrants, and most prominently, HIV-infected patients, and is most prominent in urban neighborhoods afflicted with crowded conditions and poor access to health care. Unlike previous eras in which tuberculosis was seen most frequently in elderly men, infection currently is identified in increasing numbers of young minority adults. As mentioned, the resurgence of tuberculosis is at least partially related to co-infection with HIV. HIV-infected patients are more likely to develop symptomatic disease with its associated fits of coughing than their immunocompetent counterparts, and this enables further spread of infection. Other groups prone to tuberculosis include the homeless and patients in chronic care facilities and homes for the elderly. Fortunately, since 1992, the incidence of tuberculosis in the United States has declined, reaching a record low. However, worldwide, the incidence continues to increase. Both this sustained worldwide increase in tuberculosis and the past re-emergence of tuberculosis in the United States are important reasons for the development of multiple drug resistance, that is, mycobacteria that are resistant to two or more of the first-line antituberculosis drugs. Infection caused by these organisms is poorly responsive to alternative therapy and is associated with mortality rates exceeding 50%. See Chapter 110. Tuberculosis is spread person to person through the inhalation of droplet nuclei generated by vigorous coughing. Most patients who become infected with Mycobacterium tuberculosis remain asymptomatic despite lifelong infection and have a normal chest radiograph. Infection in these patients is detected only through routine skin testing. Less frequently, particularly in those with poor immunity, the infection cannot be contained by local macrophages, and the tuberculous burden grows sufficiently to cause clinical manifestations. Adult disease, from adolescence onward, begins with constitutional complaints, followed by a prominent chronic, troublesome cough productive of mucopurulent material. The infection appears initially in the lung apices with little or no hilar adenopathy and, in advanced disease, results in lung necrosis, producing a cavity containing enormous numbers of organisms. With sufficient cough, the cavitary contents are mobilized and aspirated into other areas of the lung, where additional cavities may be formed. In contrast, pediatric tuberculosis commonly is associated with little cough even in the presence of extensive pulmonary infection. Instead, the child presents with a subacute course of poor appetite, weight loss, lethargy, fever, and sweats. The chest radiograph reveals a widened mediastinum representing enlarged hilar lymph nodes reacting to the tuberculin inoculum. In progressive cases, the nodes impinge on or erode through a large bronchus, resulting in a dense consolidation of the segment distal to the lesion. Cavitary disease is uncommon. We will now discuss non-bacterial pneumonia. Viruses, Mycoplasma species, Chlamydia species, and fungi are recognized causes of pneumonia syndromes in all age groups. The designation atypical pneumonia, distinct from the typical bacterial pneumonia seen most commonly in adults, has been used to describe the illness caused by many of these agents. And now we will look at Mycoplasma pneumonia. Taxonomically, the mycoplasmas are included in their own class labeled mollicutes. Although their small size and filterability are similar to viruses, the structure of their ribosomal RNA indicates that they have evolved from bacteria, and unlike any virus, they contain cytoplasm and can replicate in an extracellular environment. They are distinguished from eubacteria by their low genetic content. In addition, the mycoplasmas lack a cell wall and are surrounded instead by a lipid membrane. Mycoplasma pneumoniae causes human disease throughout the year, with a slightly increased incidence in fall and early winter. During the summer months when other causes of pneumonia are less common, Mycoplasma pneumoniae is responsible for a greater proportion of cases. Both infection and disease from Mycoplasma pneumoniae are common, with 2/3 of children ages 2 to 5 years and 97% of persons older than 17 years of age having detectable serum antibody to the organism. Overall, Mycoplasma pneumoniae is responsible for approximately 20% of pneumonia cases, although in enclosed populations, such as military recruits and college dormitory residents, it may cause more than 50%. Infection is spread by close person-to-person contact, and the incubation period is 2 to 3 weeks. Mycoplasma pneumoniae infections are unusual in children younger than 5 years of age and show a peak incidence in older children and young adults. Only 3% to 10% of persons infected with Mycoplasma pneumoniae develop pneumonia, with the majority of respiratory tract involvement being manifested as pharyngitis and tracheobronchitis. Asymptomatic infection is common. Mycoplasma pneumoniae presents with a gradual onset of fever, headache, and malaise, with the appearance 3 to 5 days after the onset of illness of a persistent, hacking cough that initially is non-productive. Sore throat, ear pain, and rhinorrhea often are present. Chills are seen only occasionally, and pleuritic pain is uncommon. Lung findings generally are limited to rales and rhonchi. Findings of consolidation are present rarely. Nonpulmonary manifestations are extremely common and include nausea, vomiting, diarrhea, myalgias, arthralgias, polyarticular arthritis, skin rashes, myocarditis and pericarditis, hemolytic anemia, meningoencephalitis, cranial neuropathies, and Guillain-Barré syndrome. Systemic symptoms generally clear in 1 to 2 weeks, whereas respiratory symptoms may persist for up to 4 weeks. Although the course of mycoplasmal pneumonia usually is benign and self-limited, severe respiratory disease may develop in patients with sickle cell disease, agamoglobulinemia, and COPD. Radiographic findings generally are more impressive than the patient's physical findings and include patchy or interstitial infiltrates, which are seen most commonly in the lower lobes. Small unilateral, transient pleural effusions are common, but large effusions and empyema are rare. Rentgenographic abnormalities resolve slowly, and 4 to 6 weeks may be required for complete resolution. Sputum gram stain may reveal mononuclear or polymorphonuclear leukocytes, with no predominant organism. Although Mycoplasma pneumoniae can be cultured from respiratory secretions using specialized medium, its growth is slow, and 2 to 3 weeks may be necessary for culture identification. Indirect evidence of infection by Mycoplasma pneumoniae is the presence of elevated levels of serum cold hemagglutinins. These immunoglobulin M (IgM) antibodies develop in approximately half of patients with mycoplasmal pneumonia and can be elevated in other illnesses, especially viral infection. A definitive diagnosis also can be made by demonstrating a fourfold or greater rise in serum antibodies to Mycoplasma pneumoniae. However, because this test also requires 2 to 4 weeks for results, the diagnosis of mycoplasmal pneumonia during the acute phase of the illness must be based on the characteristic history, appropriate clinical setting, and typical physical findings. Next we will discuss chlamydia pneumonia. Chlamydia pneumoniae, formerly designated the TWAR agent, after the laboratory designations for the first 2 isolates, is a relatively recently identified pathogen antigenically similar to Chlamydia psittaci. Chlamydia pneumoniae infection is ubiquitous worldwide, but only a small percentage of infections result in clinically apparent pneumonia. Conversely, approximately 5% to 15% of pneumonia is associated with this pathogen. Primary infection chlamydia pneumonia typically occurs in young adults and is characterized by mild respiratory symptoms with a gradual onset. Constitutional manifestations, particularly fever and headache, are common. The radiographic findings are nonspecific and usually consist of multilobular interstitial infiltrates. Immunity is incomplete and reinfection with chlamydia pneumoniae is common, particularly among the elderly. The definitive diagnosis of chlamydia pneumoniae-associated pneumonia depends on identification of the organism in sputum. Culture of this organism is difficult, and antigen detection systems, though available commercially, are insensitive. Next we will discuss viral pneumonia. Viruses are an uncommon cause of pneumonia in adults except in the immunosuppressed. Influenza virus, usually type A, is the most common cause of pneumonia in the adult civilian population, whereas adenoviruses cause most cases in military trainees. In contrast, viruses are by far the most common agents producing pneumonia in infants and young children, with RSV, parainfluenza, and adenovirus producing most cases. All viral respiratory tract infections occur more commonly in the winter, and rapid person-to-person spread through susceptible populations is typical. Underlying cardiac or pulmonary disease predisposes to an increased incidence and severity of viral lower respiratory tract infection, especially with influenza virus in adults and RSV in children. Radiographic findings are nonspecific and include bronchial wall thickening and perihilar and diffuse interstitial infiltrates. Pleural effusions may be seen, especially in adenovirus and parainfluenza pneumonia. The clinical pictures produced by respiratory viruses are sufficiently variable and overlap to such a degree that an etiologic diagnosis cannot be made confidently on clinical grounds alone. Although virus isolation in tissue culture is possible, 7 or more days are often required for virus identification, thus this method usually cannot be relied on for definitive diagnosis during the acute phase of illness. Serologic tests for virus-specific antibodies are used often in the diagnosis of viral infections. The diagnostic fourfold rise in titer between acute and convalescent phase sera may require 2 to 3 weeks to develop. Same-day diagnosis of viral infections is now possible through the use of indirect immunofluorescence tests on exfoliated cells from the respiratory tract. The immunofluorescence technique frequently employs a battery of monoclonal antibodies, including those against influenza A and B, RSV, parainfluenza, and adenovirus, to provide rapid diagnosis of a range of viral infections. Pause the video and carefully scrutinize Table 106.8 summarizing pulmonary complications of human immunodeficiency virus infection before advancing to the next slide. We will now discuss pneumonia in special clinical circumstances. Let's begin with pneumonia in the HIV-infected patient. HIV infects and destroys helper T lymphocytes bearing the CD4 surface molecule. These cells are critical for orchestrating a wide variety of immunologic responses. Their depletion consequently results in the dysfunction of both cell-mediated and humoral immunity. As a result, a broad range of pathogens can cause pneumonia in HIV infection, as shown in Table 106.8. The HIV-infected patient may be afflicted with pneumonia multiple times in his or her lifetime, particularly in the advanced stages of the disease, and a given episode may be caused by more than one species. The clinical presentation of pneumonia in HIV-infected persons is frequently not helpful in distinguishing one pathogen from another. The pneumonia usually is subacute in onset and consists of fever, non-productive cough, and dyspnea. Radiographically, most of these entities produce a multilobular or diffuse pattern. Some practitioners initially treat the HIV-infected patient with pneumonia empirically, covering the most common entities, bacteria and Pneumocystis carinii. More frequently, however, given the wide array of possible pathogens, a specific microbiologic diagnosis is aggressively pursued early in the patient's course through sputum induction or bronchoalveolar lavage to allow a rational choice of an antimicrobial regimen. The diagnosis and treatment of HIV-infected patients with pulmonary disease is discussed in detail in Chapter 123. Next we will discuss pneumonia in the neutropenic host. Neutropenia in the cancer patient is a common complication of aggressive chemotherapy, but occasionally can result from the cancer itself. The risk of infection in the cytopenic patient is increased significantly when the absolute neutrophil count falls below 500 cells per millimeter cubed and the neutropenia persists for longer than 7 days. In many patients, the duration of chemotherapy-induced cytopenia can be reduced by the judicious application of colony-stimulating factors. The organisms that cause pneumonia in the cytopenic cancer patient include a broad range of bacteria and fungi. Prominent among these are enteric and non-enteric, particularly Pseudomonas gram-negative rods, Streptococci, and Staphylococci, as well as the fungi Candida, Aspergillus, and Mucor. The chest radiograph may reveal the lobar pattern typical of bacterial infection in the normal host, or it may exhibit a diffuse pattern. Sometimes the pneumonia remains invisible by chest radiograph until the neutropenia resolves. Non-infectious entities also may cause pulmonary symptoms. These include toxicity from radiation or chemotherapy or infiltration of the lung parenchyma by the tumor itself. Next we will discuss nosocomial pneumonia. After the urinary tract and the bloodstream, the lungs are the most frequent site of infection acquired in the hospital. Nosocomial pneumonia is seen most commonly in critically ill patients. Several factors that predispose to the development of nosocomial pneumonia include the severity of illness, duration of hospitalization, and prior antibiotic exposure. The strongest predisposing factor, however, is mechanical ventilation intubation, which bypasses the natural airway defenses against the migration of upper respiratory tract organisms into the lower tract. This situation is exacerbated by the wide use of H2 receptor blocking agents in the intensive care unit. Such use increases the pH of gastric secretions and may promote the proliferation of microorganisms in the upper gastrointestinal tract. Subclinical microaspirations are events that occur routinely in intubated patients resulting in the inoculation of bacteria-contaminated gastric contents into the lung and a higher incidence of nosocomial pneumonia. Ventilator-associated pneumonia can be diagnosed accurately by any one of multiple standard criteria, including histopathologic examination of lung tissue obtained by open lung biopsy, rapid cavitation of a pulmonary infiltrate in the absence of cancer or tuberculosis, positive pleural fluid culture, and same species with an identical antibiogram for a pathogen or pathogens isolated from blood and respiratory secretions without another identifiable source of bacteremia. The organisms most commonly associated with nosocomial pneumonia are Staphylococcus aureus and enteric, e.g., Klebsiella or Escherichia coli, and non-enteric, e.g., Pseudomonas gram-negative bacilli, organisms that colonize the pharynx of the hospitalized, critically ill patient. The diagnosis of nosocomial pneumonia usually is established by the presence of a new infiltrate on chest radiograph, fever, worsening respiratory status, and the appearance of thick, neutrophil-laden respiratory secretions. In actuality, the diagnosis is often difficult to make in the intensively ill patient with underlying lung pathology that can itself be associated with an abnormal, changing radiograph, such as congestive heart failure or chronic lung disease. Broad-spectrum antibiotics frequently are started empirically even in equivocal circumstances, with bronchoscopy reserved for poorly responsive patients. We will now discuss severe acute respiratory syndrome. In November 2002, an extremely contagious atypical pneumonia manifested in China that since has been termed severe acute respiratory syndrome, abbreviated as SARS. The etiology of severe acute respiratory syndrome is an enveloped RNA virus, a coronavirus, referred to as SARS-CoV. The virus is transmitted primarily via large droplet spread, however, surface contamination and airborne and fecal spread are also possible. Signs and symptoms associated with severe acute respiratory syndrome include high fever, myalgias, headache, diarrhea, and a dry, non-productive cough. The respiratory symptoms may progress to shortness of breath and hypoxemia, necessitating the need for intubation and mechanical ventilation. Diagnostic tests for patients suspected of contracting severe acute respiratory syndrome should include chest X-ray, blood cultures, sputum cultures and gram stain, pulse oximetry, and identification of other potential pathogens, including influenza A and B, Legionella, and RSV. For unclear reasons, severe acute respiratory syndrome appears to be less severe in pediatric patients. Next we will discuss the treatment of pneumonia. Let's begin with the desired outcome. Eradication of the offending organism through the selection of the appropriate antibiotic and complete clinical cure are the goals of therapy for bacterial pneumonia. Therapy should minimize associated morbidity, including either one or both of these, reversible or irreversible disease and drug-induced organ toxicity, e.g., renal, lung, or hepatic dysfunction. Most cases of viral pneumonia are self-limiting, although therapy of influenza pneumonia with specific antiviral agents, amantadine or rimantadine, may hasten recovery. All efforts should focus on the design of the most cost-effective approach to therapy. Whenever possible, the oral versus parenteral route for drug administration should be selected, encouraging outpatient management rather than hospitalization. We will now discuss a general approach to treatment. The first priority in assessing the patient with pneumonia is to evaluate the adequacy of respiratory function and to determine whether there are signs of systemic illness, specifically dehydration or sepsis with resulting circulatory collapse. Oxygen or, in severe cases, mechanical ventilation and fluid resuscitation should be provided as necessary. Further supportive care of the patient with pneumonia includes humidified oxygen for hypoxemia, administration of bronchodilators albuterol when bronchospasm is present, and chest physiotherapy with postural drainage if there is evidence of retained secretions. Additional therapeutic adjuncts include adequate hydration intravenously if necessary, optimal nutritional support, and control of fever. Appropriate sputum samples may be obtained to determine the microbiologic etiology. Rehydration should be provided to replace losses that may have occurred because of fever, poor intake, associated vomiting, or all these. Finally, selection of an appropriate antimicrobial must be made based on the patient's probable or documented microbiology, distribution in the respiratory tract, side effects, and cost. Next we will discuss pharmacologic therapy. Let's begin with antibiotic concentrations. Antibiotic concentrations in respiratory secretions in excess of the pathogen MIC are necessary for successful treatment of pulmonary infections. The concept of a blood-bronchus barrier, analogous but dissimilar to the blood-brain barrier, has been used to assess the characteristics of drug penetration into pulmonary secretions. The ability of a drug to penetrate respiratory secretions depends on multiple physiochemical factors, including molecular size, lipid solubility, and degree of ionization at serum and biologic fluid pH and extent of protein binding. Studies performed in animals and cystic fibrosis patients suggest that larger molecular size favors the accumulation of drugs in bronchial secretions. This finding contrasts with data on drug penetration of other physiologic compartments, such as the cerebrospinal fluid, and may be a result of the trapping of lower molecular weight compounds in mucin pores. Nevertheless, the rate at which a drug may accumulate in certain respiratory secretions would appear to remain an important factor relative to the drug's clinical efficacy in treating pulmonary infections. The unionized form of a drug and lipid solubility also appear to favor drug penetration. It should be noted that the pH of the infected bronchi is often more acidic than that of normal tissue and blood. Fewer data are available for assessing the influence of drug-protein binding on the rate and amount of respiratory secretion penetration. Clearly, it is the free antibiotic fraction reaching the infected site capable of binding to the bacterial cell target that is responsible for antibacterial activity. Since the degree of protein binding influences a drug's ability to traverse membranes, a similar relationship would be expected within the lung. However, focusing on the absolute amount for which an antibiotic is bound to plasma or tissue proteins without accounting for the drug's overall antibacterial potency is errant. To completely assess an antibiotic's therapeutic potential in the treatment of pneumonia, or any infectious process, it is prudent to assess the antibiotic's integrated pharmacokinetic-pharmacodynamic characteristics, i.e., bacterial killing may be concentration-dependent or time-dependent, that account for the drug's degree of binding to serum proteins, tissue distribution, and in vitro potency. Thus, simply focusing on a drug's degree of protein binding is an errant, overly simplistic approach that does not account for the drug's inherent antibacterial activity or distribution characteristics. The concepts relating to antibiotic activity and overall drug penetration of respiratory secretions just outlined have supported the clinical practice of administering certain antibiotics, e.g. aminoglycosides, to achieve high peak serum concentrations on the assumption that higher, and possibly more effective, biologic fluid concentrations of the drug will be achieved. The aminoglycosides are large polar molecules that diffuse poorly into tissue and respiratory secretions. However, with increasing concentrations as obtained with once-daily dosing, increased target tissue concentrations would be expected with increasing individual doses. Substantial clinical experience supports this practice for treating pulmonary infections with certain antibiotics, i.e., concentration-dependent antimicrobials, although more data are needed to describe the relationships between these variables and clinical response. See Chapter 103. We will now discuss a clinical controversy. Prior to the availability of newer beta-lactam and fluoroquinolone antibiotics possessing consistently potent activity against multiple gram-negative pathogens, the administration of antibiotics by direct endotracheal instillation was promoted by some investigators. This method of drug administration is an attempt to provide increased topical concentrations of antibiotics that do not appear to penetrate respiratory secretions effectively while reducing the likelihood of systemic toxicity. In addition, greater local concentrations of antibiotics, particularly for the polymyxins and aminoglycosides, are believed to overcome partially the substantial decrease in antibiotic bioactivity observed when these agents interact with the purulent material present in infectious foci. Despite these potential theoretical advantages, the role of antibiotic aerosols or direct endotracheal instillation in clinical practice remains controversial. Sputum is frequently assessed, as possibly representing the pharmacodynamic interface for pulmonary infections. However, sputum represents only one of many pulmonary fluids and secretions, although sputum may serve as a reservoir for pathogen growth. These beliefs have led many investigators to assess antibiotic concentrations in sputum, frequently describing sputum drug concentrations as a ratio of serum to sputum drug concentration. Although sputum drug concentrations provide us with some insight into the characteristics of drug penetration of respiratory secretions, caution should be exercised in the interpretation of these data. Data describing sputum drug concentrations are often difficult to interpret because of differences in analytic techniques, method of sputum sampling, and random nature of sampling times relative to drug dose. Moreover, representation of sputum drug concentrations as a ratio of serum drug concentration can be misleading and most probably should be described relative to absolute drug concentration or apparent area under the drug concentration versus time curve in sputum. To more accurately describe the distribution characteristics of antimicrobial agents in sputum, research studies should be designed to allow sequential repeated sputum sampling over a dosage interval under both first dose and steady-state conditions. Thus, until greater sophistication is realized in our understanding of the relationships between antibiotic concentrations in specific anatomic sites, plasma or blood-based integrated pharmacokinetic pharmacodynamic correlates should be used for antibiotic and dose selection. We will now discuss the selection of antimicrobial agents. The treatment of bacterial pneumonia, like the treatment of most infectious diseases, initially involves the empirical use of a relatively broad-spectrum antibiotic that is effective against probable pathogens after appropriate cultures and specimens for laboratory evaluation have been obtained. Therapy should be narrowed to cover specific pathogens after the results of cultures are known. Multiple factors that help to define the potential pathogens involved include patient age, previous and current medication history, underlying disease or diseases, major organ function, and present clinical status. These factors must be evaluated to select an appropriate and effective empirical antibiotic regimen, as well as the most appropriate route for drug administration, that is oral or parenteral. For a more detailed discussion on the principles of antibiotic selection, see Chapter 104. Numerous antibiotics are available, and the majority are effective in the treatment of bacterial pneumonia. Superiority of one antibiotic over another when both demonstrate similar in vitro activity and tissue distribution characteristics is difficult to define. Our opinions on appropriate empirical choices for the treatment of bacterial pneumonias relative to a patient's underlying disease are shown in Table 106-9 for adults and Table 106-10 for children. A complete listing of antimicrobial agents for specific pathogens is beyond the scope of this chapter and is presented in Chapter 104. Table 106-11 lists dosages for the treatment of bacterial pneumonia. The list of commercially available antimicrobial agents with documented bacterial and clinical effectiveness in the treatment of pneumonia appears endless. The large number of expensive drugs mandates critical evaluation for formulary selection and clinical use. Similarities of in vitro activity, resistance to bacterial inactivating enzymes, and overall effectiveness often make rational therapeutic decisions difficult and even appear random. Some general principles, however, may be applied to guide rational antibiotic choice, including direct comparison of the antibiotic's likely attainment of the defined pharmacokinetic pharmacodynamic target correlate for specific bacterial species within the infected site. For the treatment of bacterial pneumonia with concentration-independent antimicrobials, e.g., beta-lactams and carbapenems, a plasma drug concentration exceeding the pathogen MIC for more than 50% of the dosing interval correlates with bacteriologic cure. For concentration-dependent antimicrobials, e.g., aminoglycosides and fluoroquinolones, a peak drug concentration to pathogen MIC ratio of greater than 8 to 10 or the ratio of the pathogen MIC to antibiotic area under the curve, that is AUC, of greater than 25 to 40 for gram-positive pathogens and greater than 100 for gram-negative pathogens correlates with bacteriologic cure. An understanding and application of these inherent drug characteristics would appear to be of the utmost importance for the selection of an optimal therapeutic regimen. Thus, whenever possible, identification of the causative pathogen and expected or defined antibiotic activity, i.e., MIC, is of paramount importance to the selection or design of the optimal antibiotic regimen. Pause the video and carefully scrutinize Table 106-9 summarizing empirical antimicrobial therapy for pneumonia in adults before advancing to the next slide. Pause the video and carefully scrutinize Table 106-10 summarizing empirical antimicrobial therapy for pneumonia in pediatric patients before advancing to the next slide. Pause the video and carefully scrutinize Table 106-11 summarizing antibiotic doses for the treatment of bacterial pneumonia before advancing to the next slide. Pause the video and carefully scrutinize Table 106-12 summarizing guidelines for the empirical treatment of community-acquired pneumonia before advancing to the next slide. Next we will discuss community-acquired pneumonia. For community-acquired pneumonia, the bacterial causes are relatively constant, even across geographic areas and patient populations. Unfortunately, pathogen resistance to standard antimicrobials is increasing, e.g., penicillin-resistant pneumococci, necessitating careful attention by the clinician to local and regional bacterial susceptibility patterns. Thus, whenever possible, initial therapy should be based on presumed antibacterial susceptibility and consist of older, less expensive agents, with newer and more expensive antibiotics reserved for unresponsive illness or special circumstances. The indiscriminate use of recently introduced agents increases healthcare costs and, in some instances, such as with the widespread use of fluoroquinolones, induces resistance among a significant percentage of community-acquired organisms. It must be emphasized, however, that the rapidly evolving epidemiology of bacterial resistance, including the increasing emergence of penicillin-resistant pneumococcus in many areas of the United States and Europe, forces the clinician to be vigilant and knowledgeable about antibiotic sensitivity patterns in each community. The indiscriminate use of antimicrobials for the treatment of pneumonia has contributed to the problem of antimicrobial resistance, underscoring the need for defining the optimal antibiotic regimen for each patient. Recommended empirical therapy differs among outpatients, hospitalized patients, and hospitalized patients admitted to an intensive care unit, as shown in Table 106-12. Additionally, antimicrobial therapy should be initiated in hospitalized patients with acute pneumonia within 8 hours of admission because an increase in mortality has been demonstrated when therapy was delayed beyond 8 hours of admission. Next we will discuss nosocomial pneumonia. Antibiotic selection within the hospital environment demands greater care because of constant changes in antibiotic resistance patterns in vitro and in vivo. Ironically, some beta-lactam antibiotics, which were developed to treat multiple antibiotic-resistant hospital-acquired organisms, can themselves induce broad-spectrum bacterial beta-lactamases and thereby lead to even greater problems with resistance. These facts underscore the importance of regularly documenting the epidemiology of pathogens and infectious diseases within a specific practice or institution. As a result, an antimicrobial agent for a specific infectious disease favored in one practice site may not be the most desirable selection in another despite similarities in size and patient profile. Strict and careful control and, possibly, rotation of empirical antibiotics in the hospital environment may help to limit the emergence of resistant organisms. Newer antibiotics developed to treat resistant, hospital-acquired pathogens are, however, costly. Therefore, the use must be moderated to some extent in an era where capitated hospital costs and mandated budget cuts will not tolerate careless antibiotic use. Next we will discuss severe acute respiratory syndrome. The treatment of severe acute respiratory syndrome involves primarily supportive care and procedures to prevent transmission to others. Owing to the uncertainty associated with the diagnosis of severe acute respiratory syndrome, empirical therapy with broad-spectrum antibiotics should be employed. To date, fluoroquinolones or macrolides typically have been used. Although its efficacy is unproven, patients also have been treated with ribavirin. Owing to the potential benefit of corticosteroids in the presence of progressive pulmonary disease, methylprednisolone also has been used in doses ranging from 80 to 500 mg per day. Next we will discuss fluoroquinolone antibiotics. The in vitro spectrum of antibacterial activity of systemically absorbed fluoroquinolone antibiotics, such as ciprofloxacin, levofloxacin, moxifloxacin, and gatafloxacin, suggests that these drugs have an important role in the treatment of bacterial infections of the lower respiratory tract. Numerous clinical studies describe the efficacy of these drugs for the treatment of purulent bronchitis, acute exacerbations of chronic bronchitis, pneumonia, and cystic fibrosis. The widespread use of earlier analogues, ciprofloxacin, by primary care physicians has led, however, to pathogen resistance and treatment failures, including, perhaps most important, isolates of Streptococcus pneumonia. Although newer fluoroquinolones are more active against common respiratory tract pathogens than older agents, this experience renders it difficult to recommend their indiscriminate use for routine community-acquired pneumonia. Nevertheless, these drugs may be effective alternative agents for the treatment of community-acquired pneumonia or in the initial treatment of nosocomial pneumonia for hospitalized patients and patients residing in extended care facilities. The availability of newer analogues with broad spectra of antibacterial activity, including Streptococcus pneumoniae e.g., gatafloxacin, further enhances the desirability of a fluoroquinolone as a first-line agent, expanding the therapeutic armamentarium for both community-acquired and nosocomially acquired pneumonia. At present, fluoroquinolone use in pediatrics remains restricted and limited because of possible fluoroquinolone-induced destructive lesions of growing cartilage, primarily of the weight-bearing joints. These fluoroquinolone-associated arthritic lesions were determined in animals following large doses, but have not been reflected in the human experience. The need for fluoroquinolones for the treatment of selected infections arising in pediatric patients continues, and the continued safety in these patients has served as the foundation for ongoing controlled clinical efficacy and safety trials in pediatric patients. Next we will discuss macrolide-azalide antibiotics. Among the more recently introduced classes of oral antibiotics, the newer macrolide-azalide antibiotics, clarithromycin and azithromycin, possess excellent activity against most Streptococcus pneumoniae and Mycoplasma and appear to offer viable alternatives to erythromycin, particularly in patients who are intolerant of erythromycin analogues, e.g., gastrointestinal upset, and, with azithromycin, in patients who are taking medications that may result in a clinically significant drug-drug interaction, e.g., erythromycin with carbamazepine or theophylline. Azithromycin offers the added advantage of once-daily dosing and short-course therapy because of the drug's extensive tissue distribution characteristics and prolonged elimination half-life. We will now discuss prevention of pneumonia. Prevention of some cases of pneumonia is possible through the use of vaccines and medications against selected infectious agents. Polyvalent polysaccharide vaccines are available for two of the leading causes of bacterial pneumonia, pneumococcus and Haemophilus. Influenza type B, inactivated influenza virus vaccines formulated annually to contain antigens representative of expected prevalent strains are widely available and generally well tolerated. Recently, a newly developed cold-adapted live influenza virus vaccine available as a nasal spray, marketed as Flumist, was approved. Immunization is recommended for individuals likely to experience serious complications from influenza infection, such as patients with underlying heart or lung disease or chronic renal disease and the elderly. For a detailed description of the use of these vaccines, see Chapter 122. Although they should not replace active immunization, the tricyclic amines amantadine hydrochloride and rimantadine hydrochloride may be administered for prevention and treatment of influenza infection. When therapy is initiated to healthy individuals within 48 hours of the onset of symptoms, both drugs have been proved to decrease the severity and shorten the course of illness by approximately 1 day. The recommended dose for each drug is 5 mg per kilogram per day in 1 or 2 doses not to exceed 150 mg per day in children 1 to 9 years of age and 200 mg per day in 2 divided doses in patients 9 years of age or older. Additionally, the discovery of the importance of neuraminidase to the viability of the influenza A and B virus has led to the development of the most effective drugs available for the prevention and treatment of influenza disease. Oseltamivir and zanamivir are the first of a new class of neuraminidase inhibitors. Zanamivir is available for aerosol administration, leading to some concern over aerosolization in patients with disease-induced hyperactive airways, whereas oseltamivir is available for oral administration. Both agents are effective in preventing disease, particularly if therapy is begun within 30 hours of symptom onset or exposure, e.g., epidemics, and for treatment in febrile individuals. Lastly, we will discuss the evaluation of therapeutic outcomes. After therapy has been instituted, appropriate clinical parameters should be monitored to ensure efficacy and safety of the therapeutic regimen. In patients with bacterial infections of the upper or lower respiratory tract, the time to resolution of initial presenting symptoms and the lack of appearance of new associated symptomatology is important to determine. In patients with community-acquired pneumonia or pneumonia from any source of mild to moderate clinical severity, the time to resolution of cough, decreasing sputum production, and fever, as well as other constitutional symptoms of malaise, nausea, vomiting, and lethargy, should be noted. If the patient requires supplemental oxygen therapy, the amount and need also should be assessed regularly. A gradual and persistent improvement in the resolution of these symptoms and therapies should be observed. Initial resolution should be observed within the first 2 days, progressing to complete resolution within 5 to 7 days, but usually in no more than 10 days. In patients with nosocomial pneumonia or substantial underlying diseases or both, additional parameters can be followed, including the magnitude and character of the peripheral blood WBC count, chest radiograph, and blood gas determinations. Similar to patients with less severe disease, some resolution of symptoms should be observed within 2 days of instituting antibiotic therapy. If within 2 days of starting seemingly appropriate antibiotic therapy no resolution of symptoms is observed, or if the patient's clinical status is deteriorating, the appropriateness of initial antibiotic therapy should be critically reassessed. The patient should be evaluated carefully for deterioration in underlying concurrent diseases. Additionally, the caregiver should consider the possibility of changing the initial antibiotic therapy to expand antimicrobial coverage not included in the original regimen, e.g., Mycoplasma, Legionella, and anaerobes. Furthermore, the possible need for antifungal therapy, amphotericin B, should be considered. Some resolution of symptoms should be observed within 2 days of starting proper antibiotic therapy, with complete resolution expected within 10 to 14 days. Thank you.